Good afternoon. Welcome to Grand Rounds today. Please sign the attendance record at the back of the auditorium, and also please pick up and fill out the program evaluation, give us ideas in regards to future topics and future speakers. Today it is my pleasure to introduce Dr. John Hardie. Dr. Hardie is a radiation oncologist. He did his residency in radiation oncology at the Mayo Clinic. He has been a member of the medical staff here at MGMC and McFarland since 2016. Yep. And he has very kindly accepted the invitation from the CME committee today to update us on recent developments in radiation oncology. And please join me in welcoming Dr. John Hardie.
Thanks. Looks like the microphone is unmuted. Can you hear me? Yeah. Okay. So this is a talk more about the kinds of things that we're doing now in radiation oncology more and more, as opposed to really fundamental breakthroughs in the field. It's more of an incremental talk than a spectacular one, but we'll see how it turns out. All right, so brief outline. We're going to talk first about technological advances, increase in ablative therapy as opposed to incremental therapy for cancer control. This has a lot to do with more of technological and computer advances than any fundamental advances in the science. We can do more complicated calculations, computer power is better, targeting is better, and we can do better monitoring of the patients while they're getting treated. The second part is going to be a discussion of changes away from the conventional fractionation schemes of radiation oncology, which have been around for a long time. They're safe, they are tolerated reasonably well, but with better ability to plan and more understanding of what's going on, we can start to customize the kinds of treatments that we give people more and more often. And then finally, we're going to talk about increased applicability. Specifically, we're going to talk about doing radiation in the context of metastatic disease, which is something that we are seeing a lot more of in the last year for two main reasons, both of which are listed there. The first is treating patients with a limited number of metastatic lesions. And the second is a really nice synergy between the increased use of immune modulating agents in medical oncology with the radiation-induced immune stimulating effects. And so we'll talk a little bit more about that. All right, technological advances. The first part here, this is driven primarily by the skill of our dosimetrists. A common scenario is that I will walk into the dosimetry office and I will say, I've got this great idea. What do you think about doing 36 gray in 3 fractions for lung cancer? And they'll look at me and they'll say, you're nuts. And so I'll turn around and go back to my office and I'll come up with the next great scheme. But every now and again, they will say, you know, that sounds like an actual good idea. Let's see if we can make it work. And most of the time they can. Their job is made much easier by upgrades to the planning system and upgrades in computer power, which allow them to do really sophisticated calculations on much more complicated treatment schemes. So a couple of themes for this section. The first is, don't hit what you're not aiming at. The second is, if you come for the king, you better not miss. So we'll see how that plays into this. So to make an effective radiation plan, you need to do a bunch of things. You have to really avoid delivering a toxic dose to normal tissues. That's the don't hit what you're not aiming at thing. You're not interested in hitting the normal tissues, so don't. The second is you have to actually accurately locate and you have to deliver a sufficient dose of radiation to the tumor to control it. That's the going for the king part. And that's tricky because tumors are not usually nice, round objects sitting far away from everything else. They're complicated, they're messy, they like to hide, they like to get entwined in vessels and nerves. You have to compensate for the target geometry. You also have to compensate for the inherent inaccuracies in the treatment planning system. If you try to plan a radiation course that is accurate to a micron, you're out of luck because the treatment planning system can't do it. The treatment delivery system can't do it to that accuracy. And you cannot get a patient to stay still to that accuracy either. They insist on breathing. They insist on their heart beating. They have muscle twitches. Their bowel moves around. You just can't do it. So you have to compensate for all of that stuff, and that's the you best not miss. So a couple of examples. This is an example of a patient who has pancreatic cancer. It's an unusual pancreatic cancer in that it's not progressing particularly rapidly, but it's relentless. It is a large tumor. It's abutting the small bowel. It's inoperable. It's had minimal response to chemotherapy. It hasn't progressed very fast, but it hasn't regressed either. And because of the impingement on the bowel, it's starting to get symptomatic. So we want to try to palliate this. So here's an example of the target geometry. This big mass in the center here is the tumor. That is the stomach. This is the duodenum. This is the jejunum. We got a real problem here. And this happens in 3 dimensions, right? So the tumor's a nice round thing. The stomach comes across the top. The duodenum goes around the side, around the front, underneath, and then back up. So the bowel is just wrapped around this tumor. It's pancreatic cancer. So if you're trying to palliate it, this is a really resistant cancer. You want to pound as much dose in there as you can. The problem is that the bowel is sensitive. So what we need to do is we're going to need to use multiple dose levels. We want the center of the tumor to be as hot as we can get it. We want the normal tissue that's touching the tumor to be as low as we can possibly get it. And there's a real hard limit there. We want it below the toxicity level for the bowel. We should have a minimal amount of dose crossing the boundary of the tumor, so the incoming beams and the exit beams should not go through the bowel if we can avoid it. We want to really deliver a maximum dose to the tumor. You essentially cannot overdose the center of a tumor. You can make it as hot as you like, and nobody cares. It works great. We need really good localization, right? The bowel moves. The stomach expands and contracts. The thing that we're going to be aiming at for this treatment is not the tumor bulk itself. It is the boundary line between the small bowel and the tumor. We want to have that well positioned. So we have to define some targets. So this is a rough outline of what we did. So we've got the main tumor here outlined with a bit of a margin around the outside. That center part, we're going to try to get to as high a dose as we can. This is a treatment that's going in 5 fractions. So 50 gray in 5 fractions is an SBRT ablative dose. We want the duodenum, the stomach, and the jejunum to go to 20 gray or less, which is a standard palliative dose, and they tolerate that just fine. And we want a smooth transition from this really hot dose in the center to this really low dose at the boundary without any unexpected hot spots, without any irregularities, without any portions of the high dose that kind of pouch out and hit any of the normal tissue. So bowel is really sensitive to radiation. It's really important to minimize the dose to the bowel. You can end up with perforations, you can end up with adhesions, you can get fistulas, you can cause ulcers. It's a bad deal. On the other hand, we want to hit this tumor as hard as we can, and the primary goal in palliation is don't hurt your patient. Right? If you are treating an aggressive cancer for cure, you will sometimes accept some serious long-term side effects for the patient with the option of curing them. But in palliation, you cannot cure this patient. You're trying to control symptoms, so the primary overarching goal here is just don't make it worse. And so the plan that Sam and Sherry came up with is just beautiful. All right, this is sort of a contour map of radiation dose. I want you to look at that line right there. This blue line, that is the 19 gray line, and that is sitting at the bowel. This line here, the orange one, is the 49 gray line, so that's 50 gray. That's an ablative dose there. And you get a very smooth transition from essentially 20 gray to 25 gray to 30 gray, and then it gets hot fast. This patient lined up just fine. We were using onboard CT scans. We were matching the CT scan taken on the treatment machine every day to this CT scan. The interface between the bowel and the tumor, we had no trouble getting that set up. The patient cruised through this. She had no side effects at all. It was really a great plan. It worked extremely well. Her side effects essentially gone, her symptoms from the tumor essentially went away. The second thing that we're seeing a lot more of is treating multiple targets at once. Patients are being sent with multiple metastatic lesions. They're being sent with more than one primary, or a primary and a big lymph node, or a couple of residual areas of active disease after chemotherapy, and we want to try and treat those as best we can. This is a lung cancer patient who has a couple of liver metastases. They were previously stable on maintenance chemotherapy. They started to progress. The patient was asymptomatic. And the goal is to control the liver metastases for as long as possible. This is the only site of active disease in this patient. The rest of their disease is controlled. The downside is that it is definitely possible to destroy the liver with radiation, and it's not that hard to do. So you have to be very careful about this. We want tight dose distributions around the tumors. We want to minimize the total dose to the liver as best we can. So tight conformality of the high radiation dose around the metastases, low dose radiation to the surrounding liver. The bowel is right there again, so you have to watch out for that. And there's this effect called radiation-induced liver disease, where if you radiate a large volume of the liver to low dose, you can cause liver failure. And so this is a different kind of constraint where you want to just remove the overall background dose to the liver. Another thing that you really need is that the treatment should be tolerable to deliver. If you come up with a treatment plan that requires that the patient lay absolutely still for an hour and a half while this machine scans around them, you're not going to be able to do it. We generally will not treat patients under general anesthesia. We can if we need to, but we generally don't. And so you want a treatment that you can deliver in a few minutes each day and not have the patient have to try and stay still for that long. So the plan that came up with this, it looks like that. There are 2 gold seeds that were placed in the liver by radiology, which was a wonderful job. The 2 tumors are here and here. The radiation dose here is also an SBRT dose. It's going to 50 gray in 5 fractions. That's an ablative dose for the tumor. And the color scheme here shows you the drop-off in radiation intensity. You can see that the high-dose radiation is really very tight around the tumor volumes. And more importantly, the vast majority of the liver is getting very, very little radiation. All right. 5 years ago, this would have been really hard to do. 10 years ago, it would have been impossible. The progression in treatment planning systems, in computation ability, and in the sophistication with which we can define these and with which our dosimetrists can calculate them has really improved a lot. All right, ablative therapy is also getting much more common. This is an area that is really changing the way that radiation oncology is practiced. Traditional radiation oncology puts big fields around a tumor, not particularly sophisticated tumor volumes. Usually you give a relatively large amount of tumor in small fractions over a long period of time. The goal with ablative therapy is to completely destroy everything within a small volume in a short period of time, and if possible, with no toxicity. All right, so these are short treatments, 1 treatment, 5 treatments, 3 treatments. They usually have minimal side effects. That is primarily a result of having small treatment volumes and not having any normal tissue going to high dose. Local control for these is about 90% for the tumors that you can deliver it to, which is really quite good. The downside of this is that a marginal miss is a real possibility. This is a situation where you target a tumor and the boundary of your high-dose radiation field does not include the tumor that's right on the boundary of that, or the disease that's right on the boundary of that tumor, and you can get the tumor growing back right next to your treatment field if you're not careful. The second thing that's different about this kind of treatment compared to conventional is that while conventional radiation treatments can contribute to the death of a patient, they rarely cause it outright. Right? Ablative radiation is dangerous, and if you put it in the wrong place, that patient will die fast. So you have to be really careful about this. All right. We've started doing SBRT here 10-ish years ago, and we have done a whole lot more in the last 5 years. All right, so we've done this to brain mets, to primary brain tumors. Well, the list is right there. You pick it, we've hit it with SBRT. So here's a couple of examples of treatments that we've done. This one is an SBRT treatment, 50 gray in 5 fractions to an adrenal met. You've got liver and bowel and vena cava nearby. General rule, do not ablate the vena cava. You tend to get poor outcomes when you do that. So this was a very, very careful plan. It was delivered very well, and the patient tolerated it with no side effects at all. This next one is a prostate SBRT. This was not done here. This is one that I did in training. I just happened to have a nice picture of it, so I used it. You can tell that it's not done here because there are no gold fiducials in that prostate. We always place them. But this is going to 40 gray in 5 fractions. A typical conventional prostate treatment takes 8 weeks. And so this is a big win if the patient is eligible for it and wants to do it. This is a cervical cancer. Now, when you're treating intact cervix, cervical cancer, you usually treat with about 5 weeks of conventional radiation targeting the cervix, the uterus, and all of the pelvic lymph nodes. And then you take them to the operating room and you do 5 implant brachytherapy cases. For various reasons, this patient could not get the brachytherapy, and so we are trying to duplicate the brachytherapy dose distribution with SBRT. So for this one, you have bladder there, rectum there, the tumor is right about there. The rest of this is the uterine corpus. And we designed this field to really match the brachytherapy dose distribution as best we can. So very intense in the area that it's covering, and it drops off very rapidly to background radiation outside of that volume. I have to say the dosimetrist did an absolutely phenomenal job with this plan. This is going to give 30 gray in 5 fractions, which is not quite ablative on its own, but this patient has already had 5 weeks of radiation, which stacks on top of this. So this should be a curative treatment plan. So take home from section 1. Targeting improvements and localization have better local control with less toxicity. That makes radiation available to patients who might not have been able to get it or might not have been able to tolerate it before. Ablative therapy is really changing the landscape in radiation oncology. It's being applied in more and more different circumstances, more and more complicated patients, and we'll talk more about those later on. And it is very, very effective at local control. It is really delivering minimal toxicity and very, very good control to tumors. So if we can see it, we can probably hit it with SBRT. Seeing it is not always easy, but if we can see it, we can probably get it. This is going to be a big change going forward. Our overall treatment pattern is going to lean more and more towards ablative therapies as time goes on. All right, so section 2, altered fractionation. The idea is that you come up with a safe, effective course of treatment, the conventional fractionation, and then you deliver that, and after a while you start to say, I wonder if we can vary this for individual patients. So that's the idea here. So first of all, radiation kills everything. If you deliver a large dose of radiation to an entire patient, you kill everything. So the idea is to get the radiation to the cells that you want to kill and avoid getting it to the cells that you don't. You have to balance the damage to normal tissue with the damage to the tumor. And the idea is that if you give a single giant dose of radiation, you can get rid of the tumor, but you also get rid of everything that's around it. If you can't do that, then what you do is you split the radiation dose up into smaller fractions, each of which is not necessarily lethal on its own, and you deliver them in a series building up to a lethal dose of radiation. And ideally, you build up to a lethal dose of radiation in the tumor faster than you do in the surrounding normal tissue. That's the idea of fractionation. All right, conventional fractionation, most of these were derived from large studies that were done starting in the 60s. The goal there is to have a safe and effective treatment. These are usually long treatment courses, 5 weeks, 6 weeks, 7 weeks, 8 weeks, 9 weeks, small amounts of radiation every day. They were done before computerized treatment planning. They were derived before onboard CTs and the ability to do much more sophisticated targeting. A fair number of these were derived initially before there were dosimetrists. These were the days where you had an X-ray machine and you went in there and you sat the patient down in a chair in front of the X-ray machine and you turned the beam on and you opened up the jaws to hit what you thought you were hitting. And you left for a couple of hours and you came back in and you checked the patient. If their skin was red, you stopped. If their skin was not red, you keep going. A lot of the fundamental fractionations for radiation came from studies like that way back, where you didn't even see what you were aiming at. You just opened up the jaws and you hit what you hit. And so it was very, very important to make sure that this was a tolerable treatment. You had to make sure that you did not damage the huge amount of normal tissue that you were hitting at those times. So these conventional fractionations are effective, they are tolerable, they are acceptable for doing radiation treatments, they work really well, but given the changes in technology, they are probably not optimal. So some general rules of thumb for conventional radiation, because I'm going to be talking about conventional fractionation a lot. Generally, this is 1.8 to 2 gray of radiation per day. A gray is a measure of the amount of energy that you are depositing in tissue. You can think of it as milligrams for medications. 2 gray is a really big dose of radiation as far as just general daily life, but it's not so big for the total treatments that we're doing. If you're trying to hit gross disease, you typically want a total radiation dose of between 60 and 80 gray. So if you have a tumor and you need to put 60 gray in it and you're going at 2 days per day, that's 30 treatments. And that's how you get the fractionations. All right, if you have microscopic disease, you're typically aiming at the range of 50 to 60 gray. And if you have areas that are at risk, but no obvious direct contact with disease, lymph nodes, for example, 40 to 50 gray is typical. And palliative doses are usually between 8 and 30 gray for control of symptoms, but not necessarily control of tumor. All right, there's 2 other terms I want to tell you about. The first is hypofractionation. That is a treatment course where you give bigger fractions for a shorter number of treatments. Hyperfractionation is where you give a smaller dose of radiation than the conventional for a longer number of treatments. Both of them are altered fractionations because they're not the conventional way of doing things. So why would you do this? We'll talk a little bit more about how this works out, but you can sometimes find that for particular tumors in particular locations, you can have a more effective treatment than the conventional radiation if you alter the fractionation. The second thing is patient convenience. One of my examples is I had a guy who was diagnosed with lung cancer. His daughter had been planning a wedding for a year and a half. It was scheduled a month and a half after he was diagnosed. He needed to get treated, and we just altered the fractionation so that he was done with his radiation in time to get there. He basically told me that he was going to the wedding, and if I wanted to treat him, I needed to be done before he got there. So we did it. The other thing that you can do is tolerability. If you alter fractionation, you can sometimes have an equivalent tumor control with less toxicity if you do it right. So this is why we want to do it. The next question is, can we? And as usual, there's 2 answers. Yeah, you can, and it depends. So small variations are easy. If you're going to change from 35 treatments to 30 fractions, you can do that without a whole lot of fuss. If you want to change from 45 fractions to 15, that takes work. All right, more extreme variations, you have to know about the radiation response of the tumor and the radiation response of the tissues that surround the tumor. You can't arbitrarily change the fractionation. It is as easy to mess it up than it is to get it right. There's a saying that they told me when I was in grad school in physics after I got yet another homework assignment wrong. The statement is that the problem with wrong answers is that there's so many of them and they're so easy to find. All right, you have to be careful. So some glossary. Acute toxicity is the toxicity that happens during and shortly after radiation. It's usually temporary, it usually heals. Late or chronic toxicity are the permanent changes that radiation does to a body. They generally do not heal. They can develop slowly over months to years after the end of radiation. Physical dose is the amount of physical energy that you put into a tumor with a radiation beam. The biological effect is essentially how the tumor or the tissue responds to that amount of energy. And the equivalent dose is the dose that you would have to give in conventional radiation to get the same effects as the dose that you're actually delivering. All right, we're going to talk about physical dose, that's the 60 gray or 40 gray or 80 gray, and the effective dose, that's what we use to alter fractionations. We'll be talking about acute and late toxicity as well as tumor control. Tumor control is the chance that you control the tumor. All right, so what affects effective dose? You can deliver 2 different sets of fractionation You can deliver 40 gray in 15 fractions or 60 gray in 30 fractions and get the same effect on the tumor, the same probability that the tumor will shrink, the same probability of long-term control. You can also apply the same fractionation, 60 gray in 30 fractions, to 2 different tissues and get completely different effects of that radiation. Tumor control, acute effects, and late effects all respond differently to radiation, so you cannot calculate a radiation dose for tumor control and just apply that directly to the chance that you're going to give this patient long-term toxicity. They are different things. You have to deal with them separately. Now, if you compare effective doses for several different tissues or for several different kinds of effects, you can use those comparisons to figure out which fractionation schemes are likely to be equally effective, which ones might be more effective, which ones might be better tolerated, which ones might you have to trade acute effects for late effects, and you can work out things that way. It'll also tell you pretty quickly which ones are dangerous and that you shouldn't do. All right, Brian, here we go. Every radiation oncology talk has to have an equation. It's a rule. So I wanted to show you this. This is a really simple model for calculating effective doses, and we can use it to do the kinds of calculations that we're talking about for changing fractionations. You don't have to worry about the details. What I want you to see is a couple of things. This is the effective dose. This is the physical dose. This is the 60 gray that you are actually delivering out the front of the machine into the tumor. And this is a factor that depends on how fast you're delivering. This D is the dose per fraction, so that's going to be 2 gray for conventional. It'll be 18 gray for some SBRTs. And this is a factor that comes from the response of the tissue. All right, these values cannot be calculated theoretically. You have to actually measure them. You have to do cell cultures, you have to expose those to different kinds of radiation and see what the survival fractions are. So those are empiric things. They are measured, they're tabulated. Some of them are not known. The key thing to look at here is that if you want the effective dose to remain the same and you increase the total radiation you're delivering, you have to decrease the fraction size and make this term smaller to keep the two the same. If this gets bigger by a factor of 2, that has to get smaller by a factor of 2 so that the whole thing stays the same. All right, so we have a plot. I just made this plot up. This doesn't have anything to do with reality. This doesn't correspond to any particular tumor or actual tissue. I had a drawing program, so I just kind of scribbled it out there. Okay, so a couple of things about this. I'm going to show you a couple of more plots like this. What you do is you pick a point. This is going to be a conventional fractionation scheme. On this axis is the fraction size. So let's say 2 gray is right there. This is the total radiation dose you give, so this would be 60 gray right here for a 60 gray in 30 fractions treatment, a conventional treatment for, say, lung cancer. What you do then is for each of these things, for the tumor, for the acute toxicity, for the late toxicity, you calculate the effective dose at that point. And then you use that equation that I showed you to walk along these curves by going this way increases the fraction size. So you increase the fraction size and decrease the total dose to keep the effect of the radiation the same. So each of these curves is a whole set of different treatments that will have the same effect on the tumor. You do the same thing for the late toxicity and for the early toxicity. The other thing you need to know about this plot is that going that way is increasing effective dose. So more side effects, better tumor control. And going this way is less effective dose, less side effects, less tumor control. So a quick example here. If we start with this conventional fractionation and we decide that instead of 2 gray, we want to do 3 gray a day, that'll be somewhere around here. We went along that curve, so the tumor control is going to be exactly the same. The tumor will behave the same way. We'll get the same chance of tumor kill. We'll get the same chance of long-term control. What you see, though, is that we are now below the curve for late toxicity, which means that this patient is going to have less long-term side effects from that radiation treatment than from the conventional one. On the other hand, we are now above the acute toxicity curve, which means that the acute toxicity, the difficulty of getting through that radiation treatment is going to be worse. It's going to be more painful, more difficult, more more demanding for the patient to get through that treatment. Whether that's a win or not really depends on the situation. If you work these out for different kinds of cancers in different locations of the body, you get a whole set of different curves. I've got 3 kind of schematic examples to show you. So this first one, this would be typical of something like esophageal cancer. This isn't really esophageal cancer, but this is what it looks like. So for esophageal cancer, you have the acute toxicity curve here, the late toxicity curve here, and the tumor control curve right in the middle. So this is our conventional treatment for esophageal cancer, 50 gray and 25 fractions. If we want to go to a shorter treatment course with bigger doses, we would go down here, and what you would see is that you would have less acute toxicity that way, but a lot more chronic toxicity, more problems, more risk of esophageal fistula, more risks of stricture, more risks of obstruction. They would have less nausea, less fatigue, less esophagitis, so the treatment would be easier to get through. You'd have the same tumor control, but you're going to give them more long-term problems. So that's probably not a good idea. On the other hand, if you go this way, you're now below the late toxicity curve, so your risk of fistula and everything else down the road is less, but you're above the acute toxicity curve, so the treatment is going to be harder to get through. And esophageal cancer treatment with concurrent chemoradiation is already really hard for patients to get through. So that's not a win either. So if you look at this kind of situation where you have an esophageal cancer with relatively sensitive tissues around it, you end up with the conventional treatment being pretty much the optimal one. It's the best balance of tumor control, late toxicity, and early toxicity. It is really difficult to alter the fractionation for something like an esophageal cancer. You end up with worse toxicity either way. There's no big win there. So a patient with esophageal cancer who wants an altered fractionation is going to be told, no, we can't do that. All right, this is a situation like oropharynx cancer. All right, the big issue with oropharynx cancer is not really tumor control. Radiation controls oropharynx tumors really pretty well. The big issue is that the acute toxicity is brutal, and the late toxicity of radiation to the head and neck is life-changing. Right? Your sense of taste, your salivary function, your swallow function is altered permanently, and it never returns. So, in this case, you have the situation where the toxicity curves are both on one side of the tumor control curve, and that's just the way that the tissues happen to work out. So if you start here with the conventional fractionation, this is 70 gray and 35 fractions, so it's a 7-week treatment. Moving out here to make the treatment shorter gives you the same tumor control, but worse late toxicity and worse acute toxicity. So the treatment gets harder to tolerate, and it gives you more permanent long-term damage. Not a good result. If you go the other way, though, your tumor control is the same, and you have less late toxicity and less acute toxicity. And for a long time, before we were doing concurrent chemoradiation for head and neck cancers, that's the way we treated them. That would be hyperfractionation. We would treat them BID for 6 weeks. So 60 fractions over 30 days, 2 treatments per day. You got the same tumor control. The patients had less long-term problems. The treatment was still difficult. So this kind of system leads you to do an altered fractionation that's favorable if you go to smaller fractions and longer treatments. Well, that doesn't get the guy to his wedding, but it will probably make it easier for him to taste the wedding cake when he gets there. The other option is to go the other way, and this is sort of typical of breast and prostate cancer. In this case, the toxicity curves are on the same side of the tumor control curve, but they're switched. So in this case, this would be, for prostate, this would be 80 gray and 40 fractions. If you go to bigger fraction sizes, you get the same tumor control, but you're below the toxicity curves in both cases. And so you can make the treatment shorter, you can get the same tumor control, and the patients will tolerate it better, both short-term and long-term. That is the reason that we are treating a lot of our prostate cancer patients in 4 weeks now, specifically for this this reason, because the toxicity gets better, tumor control stays the same if you go to bigger fractions. Now, if you lose your mind and you try to go the other way, you're just going to make everything worse, and so just don't. So, take home for section 2. Conventional fractionation is being used less than it was before. Fractionations are being tailored more towards the individual patients, their individual tumors, and the locations of those tumors than we were doing in the past. This leads to more convenience for the patient. It leads to less toxicity. It leads to faster treatments. The problem is that it's no longer one size fits all. The conventional fractionations were designed so that you could apply them to essentially everybody and you would get a reasonable outcome. As we just saw, there are times when you cannot change the fractionation to the way you want it to go. You'll end up hurting the patient. And so it's no longer a one-size-fits-all kind of thing. A note for people who are sending patients to us. Be really careful now about telling patients how many radiation treatments they're going to get. It is changing fast, and it varies from patient to patient based on individual patient condition, individual patient tumor, the locations, the kinds of treatments we're going to be giving, whether or not they're getting chemotherapy. It is really tough to predict before you actually sit down with the patient and look through their chart and think about the possibilities. It's really difficult to say what their radiation treatment is going to be. So just use a little caution. All right, the third part is approaching actual science. It doesn't quite get there, but it's approaching. Traditionally, radiation for metastatic disease was that you would have a patient that had a particular tumor that was causing pain or putting pressure on the spinal cord or blocking an airway or something, and they would be sent down to us and we would give them a short course of treatment that was not designed to get rid of that tumor. It was designed to shrink it enough to make the side effects go away. It works really well when you do that, but it doesn't affect the patient's overall survival. It doesn't affect their quality of life very much, except for the particular side effects that you're addressing. And more recently, there's been some work done on what happens if you are in a situation where you can give really intense radiation to every site of metastatic disease. Well, what happens if you do that? Well, if we can deliver ablative therapy to every site of disease that the patient has, and I'm not going to say this happens because I don't think it does, but if you could, that is potentially a cure, right? If you destroy every tumor cell in that patient's body, that's a cure. Now, we can't do it. We can't see all the cells. If you have metastatic disease, you know they're in lots of places that you don't see. But if you can control all visible disease for some amount of time, then that is a period of time where the patient is not progressing, they are not declining, and you can end up with better quality of life for a much longer time. The second thing we're going to talk about after we get done with this comprehensive radiation part is this idea of something called an Abscopal Effect, which is where you do radiation to a tumor in one part of the body, and tumors in other parts of the body respond by regressing. All right, it's an immune-modulated effect, and the fact that we are getting more immune-modulating agents used in medical oncology is making this happen more often. Okay, oligometastatic disease. Oligometastatic disease is disease that's not loco-regional anymore. There's metastases, but there's a small number of them. What we mean by a small number is changing. About 10 years ago, we meant 1 to 3. Now we mean 10-ish. And not always then, with sometimes more than that. So this can happen in 2 ways. The first way is you start with a loco-regional cancer and then you come back for a restaging scan and you've got 1, 2, or 3 more lesions that are now metastatic. The other way is you have widely metastatic disease, you get standard chemotherapy, immune agents, whatever else, and all of the disease sites except a few respond. Either way, you have a few sites of active metastatic disease. So the idea here is you continue whatever therapy is working. If they're on chemotherapy and it's working, you keep using it. If they're on an immunotherapy and it's controlling the disease in most parts of the body, you keep using it. And then you try to deliver a local treatment to every site of residual disease. That can be either radiation or surgery or a combination of both. Both of them have potential toxicities. If we have a really large subcutaneous nodule, surgery is probably a better way to go. Radiation is going to cause an ulcer there that probably won't heal. And so if a surgeon is willing to go and take that out, that's a better way to control that one. If you have 3 or 4 nasty lesions in the middle of the liver, radiation is probably the better way to go. The surgery is going to be difficult, particularly in a patient who is status post-chemotherapy with metastatic disease. The idea, though, is you find every site of residual or progressive disease and you treat all of them. It's a nice idea, and the question is, does it work? So here's a couple of studies. These are not the only ones. These are just the first 3 that came up on my search. All right, the first one is a breast cancer study, published 2018, 54 patients, 92 lesions. The patients were treated with comprehensive radiation, which was almost always SBRT. And at 2 years, they had a local control rate of 97%, an overall survival rate of 95%, and a progression-free survival rate of 54%. That is incredible for metastatic disease. The second one is non-small cell lung cancer. This is a randomized prospective trial, 49 patients. They had metastatic disease, which was stable after first-line chemotherapy, and all residual sites of disease were treated. They were randomized to either ablative therapy to all metastases plus maintenance therapy, or just maintenance therapy alone. This trial was stopped early. They got to their first analysis point, and there was a big enough difference in progression-free survival that they decided that it was unethical to continue the trial. They continued following those patients for about 5 years, and when they published their results, the median overall survival was 41 months in the patients who got radiation and 17 months in the patients that didn't. That is really shocking. This next one is a randomized trial with all histologies. Most of them were breast, melanoma, and lung, but there were a whole bunch of them there. It was about 100 patients. They had between 1 and 5 metastases. The disease was controlled with standard therapy at study entry, so they were not progressing when they entered this study, but they did have residual disease, stable disease. They were randomized to SBRT to all of the lesions or just standard of care. And at a 25-month follow-up, the median overall survival was 28 months for the standard of care and 41 months for the ones who got radiation. The progression-free survival doubled from 6 months to 12 months with comprehensive radiation. Quality of life was better in the group that got the radiation. All right, and there's a whole bunch of retrospective studies, reanalysis that looks at similar kinds of things with similar kinds of results. All right. These results started to get published really commonly in the last 3 or 4 years, and in the last year, we have seen a really big increase in patients like this being sent down to us, and we are doing this whenever we can. It works very, very well. So the next thing is this Abscopal Effect. We're going to get a fairly irreverent history lesson. So Dr. Moll was a radiation oncologist in the 1950s, and he noticed a weird effect. He had a patient. The patient had a tumor that he could treat with radiation, and they had a couple of other tumors that you couldn't. And so he treated that tumor, which went away. And then as he followed the patient, now remember, in 1953, there was not a lot of chemotherapy being done for most tumors, so the radiation and surgery was it. So these patients were then followed, and in a couple of his patients, the other tumors went away too. The tumor that was treated by the radiation responded in a couple of weeks. The other ones responded over months afterwards. He called that the Abscopal Effect. He noted that untreated tumors would sometimes regress. He proposed that this was immune modulated. It's either immune system or magic. You can't really tell at this point. And he called it the Abscopal Effect, using pretentious Pseudo-Latin and Greek, which means away from the target. From 1953 to 2014, about 40 other cases of this were reported in the medical literature. I did not look at all of them, I have to say. And there was a fair amount of work done with mice where you induce a tumor and you treat it in various different ways, and you look to see if you can figure out what makes the Abscopal Effect more likely, what makes it less likely. nothing really went anywhere. This was not reliable enough to count on. It didn't happen very often. It was a weak effect when it did happen. And so every now and again, somebody would get interested in it and check to see if they'd ever seen it or do a couple of experiments, but really nothing much happened. But the mouse studies did give us an idea of sort of how this works. So radiation kills cells. It damages the DNA. It damages the molecular environment of the cell. You end up with altered antigens. These new antigens get spilled out into the surrounding tissue. They induce various cytokine chains. T lymphocytes get attracted, dendritic cells get attracted. They get sensitized to these antigens, and they then migrate somewhere else in the body. And when they find antigens that match, in other words, other tumor cells, they can sometimes attack them. Right? It sounds nice and simple and straightforward. This is life. It's not. So when you look at what's going on with radiation, what you discover is that the conventional fraction sizes, 1.8 or 2 gray per day, almost never induce enough immune system response to cause an abscopal effect. If you do daily fractions in the 5 to 10 gray range, it happens more often, but it's still rare. Interestingly enough, Dr. Moll was treating melanoma patients. The conventional fractionation for melanoma is 5 gray per day. If a little is good, a more is better idea. If 5 gray is good, then maybe 15 gray is better. No. If you do fraction sizes greater than 10 gray, 12 gray, then you end up inducing a whole lot of inhibitory chains that tend to suppress the activation of the white blood cells. Now, another problem is that the immune response is carried by white blood cells, which are really sensitive to radiation. So if you're treating somebody conventionally, you will give them a 2 gray fraction, which will not really induce a big immune response, but it'll induce some. And the cells that are going to get activated show up in the tumor within about 6 hours, and then they disperse over the next 5 to 10 days or so. The problem is that the next day you come along and you hit the tumor again. And while 2 gray doesn't induce many lymphocytes, it sure kills the ones that are there. So you just activated all these lymphocytes, and then you come through the next day and you kill them all. So you tend to suppress the immune response that you're trying to get. The other thing that makes it worse is if you're doing conventional radiation, very often you are also treating the draining lymph nodes of the tumor, which is the escape path for these activated lymphocytes. So even if they happen to squeak by and get out of the tumor, they're still in those lymphatic paths for the next couple of days, and we hit those too. All right, what happened in 2014? Well, this set of medications started to get approved. These are all immune modulating agents. Ipilimumab is one that's used with melanoma. Pembrolizumab is used with everything now. And these started to encourage, to enhance the immunogenic response of radiation for tumors. And so you start seeing an increased number of reports of the abscopal effect being seen in patients who are getting these agents. This really has a lot of potential. It allows a possible way of delivering at least inhibitory treatments to cancer cells in the body that you can't see. Right? In order to hit something with radiation, we have to be able to see it. If you have microscopic disease, we can't see it, and you don't know it's there. And so if you can get to a point where you can count on this effect, at least a little, you may be able to provide better long-term control. If you're doing comprehensive radiation to all visible disease, and you can add in one of these immune modulating agents, you may end up doing at least mostly comprehensive treatment to all of the disease, visible or not. Now, the downside is that the current knowledge of the best way to enhance the abscopal effect with fractions of 5 to 10 gray, 1 fraction a week, 1 fraction every other week, that does not work for controlling tumors locally. So you have to choose. Do you want to treat to encourage the abscopal effect at the expense of controlling the tumors that you're trying to control or not? And the answer is definitely no. We don't want to do that. So a lot more work needs to be done to see if we can get to the point where this is a clinically useful thing, but it's really intriguing. It's encouraging. It suggests that there might be some more detailed techniques coming down the roads that we might be able to exploit to give patients with metastatic disease better outcomes. We're not there yet. All right, take home for this. Altered fractionation, ablative therapy, better targeting of disease sites, decreased toxicity, and maybe the abscopal effect are allowing us to provide patients with metastatic disease prolonged periods of stable disease, regressed disease, no progression, and improved quality of life. On the studies that we were looking at, the overall survival was almost 4 years in the patients who got the comprehensive radiation and 1.5 for the patients who didn't. That's a big gift. Stay tuned, it's gonna get interesting. I don't know where it's gonna go from here, but it's gonna get interesting. Any questions?
Hey, John.
Hi.
Thank you very much. I was interested in the maps that you did on an axial view. If you did those on coronal or sagittal, especially in the abdomen where you get diaphragmatic excursion, I assume it wouldn't be quite so tight.
It depends. We will do sometimes 4-dimensional CTs where we track breathing. And down the road a bit, we're going to be having a breath hold treatment where the machine will only turn on when the patient is at full inhalation, and so we stop that motion. It's coming.
Awesome. That's cool.
All right, lunchtime. Thank you.